Good afternoon, everybody, and welcome to the Commission on Excellence in Innovation in Health's Improvement Showcase, Series 5 we're up to, and our Series 5 theme is vulnerable populations. Before we get started today, we would like to acknowledge that I'm hosting this session today from the lands of the Kaurna people. And I'd like to acknowledge that I respect their spiritual relationship with their country. We also acknowledge the traditional custodians of the various lands on which you are all situated today, and also like to acknowledge any Aboriginal or Torres Strait Islander people who are participating in the session. I pay my respects to elders past, present and emerging, and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters. So before we get started, I'd really just like to talk a little bit about the Commission on Excellence in Innovation in Health and recognise our vision, which is together, let's create better healthcare for all South Australians. We really want to see a system where we come together. CEIH is a small organisation where we can bring people together and create, so actually come up with new ideas. Doing the same thing over and over again isn't working. So how can we create and imagine new ways to have better healthcare? And better isn't excellent. Better is actually about being able to measure that we're doing better. We're actually moving forward for all of the people in our state. So what if the big idea was connecting all of the small ideas? And that's really why we host these sessions, is to understand how we can connect you all together. Certainly we do have people who join us from interstate and even overseas sometimes, but really this is about South Australia and how we can connect you across our state. Just for some housekeeping, we're going to have a presentation today from our guest speaker, who I'll introduce very shortly. We'll just ask that people keep their microphones on mute and can keep the cameras off if you choose to, and we'll record the presentation from our guest. At the end of that presentation, the recording will be turned off, and really we do that to give you the opportunity to be able to turn those cameras on and feel like there's an opportunity to have an open and honest conversation that's not being recorded. For the Q&A session. So as I've mentioned, the series today is vulnerable populations, and we had a presentation last week which was well received from our Professor Chris Barnett, who is the head of Paediatric and Reproductive Genetics Unit at Women's and Kids, and also the chair of our Clinical Genomics Statewide Clinical Network here at the CEIH. And he talked to us about thalassemia in pregnancy. Today, we're very pleased to welcome Associate Professor Josephine Thomas, who is here to talk to us about the transition from paediatric to adult services with complex medical needs. So how MACS can help. We're really excited shortly to introduce you to Jo Thomas, and grateful to her for being with us today. And then next week, we're looking at a project down in the south of Adelaide, which is building a positive culture in the REPAT neurobehavioural unit. And we'll be welcoming Dr. Michael Page from the Southern Adelaide Local Health Network for that session. So we hope that you're able to join us next week as well. So the Improvement Showcase, as I've mentioned, is about bringing people together and having the opportunity Thursdays at 1 o'clock, but then online whenever, recognising that we can't always drop everything at 1 o'clock on a Thursday. So we do these recordings so you can go back to them. Very much focused about bringing healthcare teams together, providing a space to explore what others have learned and keeping it simple. So this isn't always about people being able to present something that they've published. It might be something that is just a learning or an achievement. So before I hand over to Josephine, I would like to just do a little bit of a plug, I guess, for us to say, if you've got a story to tell, if you've succeeded in solving a problem, if you've learned something whilst trying to solve a problem, or if there's a theme that you'd like us to explore, because at the moment we're very much coming up with these themes here at CEIH. If there's a theme that you'd like us to explore over a period of 5, 6, 4 weeks, whatever it might be, then please get in contact with us at ceih@sa.gov.au. So I'm just going to stop sharing my screen now and introduce our speaker for today, Associate Professor Josephine Thomas from Central Adelaide Local Health Network. Thanks so much for coming to speak with us today, and we're very, very grateful and very excited to hear your story. Over to you, Jo.
Thanks. Just share my screen and get my PowerPoint, because what's a presentation without a PowerPoint? Thanks very much to CEIH for inviting me to give this talk. I really felt a little bit out on a limb when I was first invited to do this, because as I'll explain as I go on, the design of this sort of service for this vulnerable population really feels like an accidental model of care rather than a planned one. But I'll elaborate on that. I can say, though, that the model of care I'll present to you today is one for me that demonstrates both a holistic approach and an interprofessional model of care, which hold at their core the value of patient-centred approaches. And I think that for me, that's really embodies my philosophy toward care, and that's why I've stuck with this clinic for as long as I have, and I've been there since I was a registrar. Might tell you something. Maybe it's about me, I don't know. So who are MACS? So at the moment, MACS is this is some of us in the photo, but it's 2 clinical nurse consultants, 2 pharmacists, which is only actually 1 day a week for one of them and 1 session a week for another. It's a bunch of clinicians, general physicians and pharmacologists, some of us dual trained, some other subspecialists, and that's sort of ebbed and flowed over time as to who that has been. It's often been cardiology and endocrinology. Also, we have some time from a psychologist, which we've had on and off, and we've had input from allied health on and off. And that's really the interprofessional team of people that we have. I'm going to start, before I talk about the actual vulnerable population that we look after, I'm going to start with how MACS was developed. Not a big, long story, but it was really developed to support patients with multiple and complex chronic conditions who are at risk of being hospitalised. Those people that tended to turn up again and again and again to the Royal Adelaide Hospital with exacerbations of chronic illness or new problems. And the idea was that we would combine patient-centred practice and a shared care approach with other healthcare providers. We really wanted to enable patients to optimise their health and wellbeing, and this is still the main ethos of the clinic. What I've got up on this slide is really what MACS is all about. Reducing hospital admissions is part of that deal, because that is important to both patients who mostly dislike having to come into hospital, and also really important for a KPI that the organisation supports and can endorse financially as well. The interprofessional team that we have in MACS is a key component of the service, and it's a key part of how I enjoy working. I really enjoy working as part of that team, and I call myself an interprofessional. We demonstrated benefits of this model of care recurrently, and it really transformed to become what we now call MACS in about 2009. And I say about 2009 because I'm not great with time points, but also because we had this clinic that Sapir Shakib designed as a drug optimisation clinic in the beginning. And so we were really taking on people with multiple medicines, multiple comorbidities, and looking at how we could best organise their care, so that holistic approach. And so the benefits that have been demonstrated at various time points early on in the clinic were those of reducing readmissions, improving survival, and addressing things like polypharmacy. And these are just a few publications that arose out of the clinic, but there are many other, I think, academic studies that arose from the population we looked after and the model of care benefits that we saw in front of us from looking after those people. Personally, I was one of the physicians in the clinic, and I was there since registrar time with both a pharmacology hat and a general physician hat, but I was one of the physicians that attracted a younger cohort from the start. And I think the joke was the patient that I had that was 21 with 21 medicines. And it's not really a joke, it's not funny at all, but that was the kind of clientele that started to be referred to see me. And that's how I come to talk to you today about a vulnerable population. And the vulnerable population of young people with complex medical issues transitioning to adult services is the population that I wanted to mention. These young adults come across to the RA where I work at a time of massive change for themselves, of uncertainty and instability. And that's because at the time they turn 18 or thereabouts, and I say thereabouts because it's really complicated for these people. The Women's and Children's has increasingly needed to be able to transition their care because of, I guess, a multiplicity of factors. A recognition that the funding beyond 18 years is no longer viable for that service because it has increasing pressures like everyone. Also, I guess, increased survival of this group. So there certainly is an increased surviving population now that makes it into adulthood. And so at the time people turn 18, they are becoming adults or have become adults. They are completing their schooling. So if they have profound disability, for example, they may have school up to age 18 that then finishes. They have a change often in their funding arrangements. And so there's so much going on for these people. And yet at that very point in time, they are then coming to a whole new model of service provision, a whole new set of service providers in their healthcare arena. What could go wrong? So why does MACS work for these young adults? And I say that it has been an accidental thing because what happened, I think, was a trickle, and now that's turned into a significant torrent of referrals that come to our service. I really believe that because MACS offers a holistic and patient-centred model of care, it's really well suited to these young adults with complex needs. And although we have data to say what happened early on in MACS when we started off looking after heart failure, and we were very successful, and then that population then actually got taken over by cardiology primarily. What's happened with this population is that it's just a growing need, a growing referral base that's occurring over time. And so it's not so much a design, but the proof of concept that a model of holistic care works really, really well. So I'll talk a little bit about what we do. Primarily, I think what happens is we build relationships and we foster trust. And that's done in a multitude of ways. But if you can imagine being a young adult who is referred across to adult services, the number of referrals is usually quite significant. So there are referrals to multiple subspecialties, referrals to multiple other allied health services. So if I just give you an example, a young adult who may have something like a feeding gastrostomy or jejunostomy or both, with a tracheostomy, and is non-verbal, is wheelchair bound, will be referred to a multiplicity of services depending on their various comorbidities. If they have epilepsy, they'll get a neurology referral. They'll get referral to the dietitian, to the gastrostomy supports within the gastroenterology unit, and they will have no idea of which of those things are going to happen first and when and how and what those providers will look like and what they'll need. So at the time that these referrals are made, there's great uncertainty, and we can help because if these people come into our service, we tend to prioritise their referrals and appointments. We tend to try and define their needs more closely, spend time talking to them about what's important to them, what they're currently managing, what they see as active unsolved issues, and what they see as their major priorities. We take some time to ensure that the different needs that the person or their family are targeting as important have a pathway to be met. So they may be uncertain, for example, around how they're going to access certain services, get certain materials, equipment. And so we just try and define that for them within the adult service. We then, over time, will start to empower both the patient or their carers or both and their GP in their ongoing management. And the last point here is about how we really do look to reduce the involvement of multiple services. And that might seem very harsh, but in fact, I think it's counterproductive to have so many providers involved in your care. Recognising that the complexity of some of these conditions does require specialised input. I'm not negating that at all, but I think that when you have a schedule of appointments, that means you barely see the light of day for anything other than travelling to appointments. Being able to give someone their life back, empower them to make choices around which appointments they might need to attend is really important. And if you have good coordination of care, then my promise to these young adults is that I will access those subspecialists or subspecialty services when it becomes important and when it's needed, or consult them. So it doesn't always have to be a direct appointment. And that's really an important way of managing things. For example, if someone has what looks to be a fairly stable comorbidity with urology issues, they've had previous urology procedures, they may have a complex urinary reservoir. I'm in close contact with my urology colleague, Ashani CALHN, and I will talk to her about the fact that I think perhaps things are stable at the moment. However, down the track, if something new arises, a new problem arises that's urological in nature, I'll get in touch with her so she can expedite an urgent appointment. And that's one way that we can stop people worrying about the fact that a waiting list for an appointment might be really long. So it sounds sort of simple, and it kind of is. It makes a lot of sense, but you have to be prepared to, I think, take on almost anything. And that's where being a little bit fearless, being a little bit, I guess, I don't know, just content to go with the flow is really important. And that's one of the, I guess, binding features of all of the professionals in the clinic, is that they're really happy to just problem solve and take things as they come. One of the things that I like to do, and this messy slide I'll explain, it's just to help me organise my thoughts. I like to sort of centralise the thinking of multiple professionals in one ED presentation plan. And you can probably say, what on earth are you talking about? Why is ED the focus? Why is the hospital the focus? And it's not. I mean, it's the focus of my world often because that's where I sit. But for a young adult coming across to adult services, one of the most scary things for them and their family is the idea that they might have to suddenly present to the emergency department of somewhere like the Royal Adelaide Hospital, and they just don't understand how that's ever going to work for them. And that's a real and present danger, and it's a source of great fear for them. So we sort of need to go through things, and this takes a few appointments in getting to know them, and as I said, prioritising what their needs are. But I can start to draw together things like, well, if it's a young adult with epilepsy, their seizure plan could go into this. Their home management plan for various things. I mean, it might be simple stuff like constipation because they've had a couple of episodes of fecal impaction. So that'll go into their ED presentation plan about what do they do at home? What's their strategy for managing? And sometimes when I start to write these things down, it's the first time that all of these things have been clearly articulated in one document. They may have been articulated before or not, but they may have been articulated before in separate documents. We try and bring them all together. So I basically have a document that then has contact details for people that are important, for just those that care for someone at home, those that care for someone in different settings. They may have a private cardiologist and a public neurologist, and they may have me that they're seeing. They may have other things that happen. We've got all those contact details listed. We list things like the legal and guardianship decision-making, people who's got authority for these things. There might be care plans that support workers utilise. there might be a list of likely acute presentations and the management. So for example, someone who's got lots of different things like a ventriculoperitoneal shunt, every time they come to ED, people are going to worry about that. But if we say, well, actually, that's rarely been a problem, but these things have been more of a problem, that helps the ED people approach this person. And it just tends to demystify what the priorities might be if something goes wrong and that person has to present to hospital. I've had great success with this from before we moved to the new RA, and it mainly has to be a bridge, because previously the emergency department were using a different record keeping system, and they certainly started using Sunrise before the rest of the hospital did. So it's been great to have something that sits electronically up there, but also can be a paper held document that a young adult can have with them or with their carers. And so it just outlines some of the things that others might need to know. And for some people that's really important. They may have a genetic condition that's really rare, and just linking others to a document that outlines that or says, you know, it's okay, this is really rare, but these are the things that are important to know about this condition, just takes the sting out of things, so that they're not having to explain it themselves all the time. And that's a recurrent theme that I hear, is I always have to explain everything about myself or everything about my son, my daughter, because people don't know, and they find that extremely wearing and very stressful at a time where there's acute disruption like an illness. So what are some of the challenges these people face? So I guess there's different vulnerable young adults that I might think of coming across to us from the paediatric sector, and some of them have completely non-verbal. They may have some aids for communication, or they may have very little ability to communicate. And for them, we're really dealing with their parents or other support workers. There are others for whom there's quite a lot of ability to communicate, and so their needs might be different, and they might have some more concerns about how they're going to start taking care of their own or assume responsibility of their own care. But no matter which part of the spectrum these vulnerable young adults sit in, I find that frustration is a universal problem in their transition. And the challenges are things like lost referrals. You wait and wait and wait for a letter of an appointment to arrive, only to find that when you call in, that referral doesn't seem to exist, or hasn't met its mark. It's been, you know, lost, whatever that means. Or referrals that aren't actioned because they were deemed not appropriate. For many of the services that are offered in the paediatric sector, there doesn't feel like there's an equivalent adult service, or it's got a different name or a different focus. And so it's a really confusing landscape. I mentioned earlier that there are multiple referrals in a sort of a blunderbuss approach that occur. And that's really difficult, because how do you prioritise and how do you chase so many different referrals? And there's terrible confusion. If the HEN service at the Women's and Children's provided this kind of information and this kind of process around how you access things, but then you move to the gastroenterology service at the RA and things work differently, that's very confusing. The timelines are just unclear. Do you have to transition spot on at 18? Can you keep attending ED at Women's and Children's until 20? We've all heard that some people got away with that. And so there's a lot of confusion around what the actual cutoffs should be or are. And just overall a lack of information and communication. I'm constantly frustrated by the fact that I can't access the full medical record of a young adult coming across. But then again, maybe I'm saved, because how would I review 20 years of notes? So I don't know. There's different funding arrangements as well. So, and I'll talk now about medications. Funding around medications is probably one of the most frustrating things. So in the adult system, we rely on the PBS, And then if you have to do something that's outside the PBS, then there's a lot of paperwork and application for that. As a pharmacologist, I don't mind a bit of paperwork to achieve something that I think is the right medicine. And that's not a problem, but it's a whole different system. And we're largely expecting the general practitioner to take on the prescribing for someone in the adult sector. However, if you've been a client at the Women's and Children's, you may well have had all of your things provided by their pharmacy without much question in a one-stop shop model. There's miscellaneous items like saline flushes for ports or for pegs or for other things, and how do they fit in? You know, how do you get those things? Because our pharmacy at the hospital isn't particularly enamoured with providing costly things unless they fit in their budget and funding model. And then there's a lack of evidence beyond the age of 18 for some medicines. So again, you get that defined cutoff at 18, which, you know, is that really a thing? Did it work at 17 and a half, but it's not going to work at 18? But nevertheless, you're faced with difficulty with funding. And if I apply to my Drugs and Therapeutics Committee for a medicine that doesn't have evidence in an adult, then that's hard to get the support for that. So we often need to apply for funding from our Drugs and Therapeutics Committee for a period of time to allow a transition and an exploration of whether we need to use a different medicine in that instance. So you can see that the pharmacist in the MACS clinic becomes then a really important person. Now, future planning is one of the things that I think we take on over time in these young adults. And sometimes it comes up quickly and sometimes it takes a lot longer to emerge as an issue. Resuscitation is often something that comes up really quickly, particularly if they're going to present to hospital, because in the adult system, it is a question that gets asked with every admission in someone who's got complex comorbidity, and that can be very confronting. So preparing people for that discussion is vital. We're often in the position of needing to broker or discuss more sustainable models for ageing carers. As carers develop their own medical issues, they may then need greater help in looking after the young adult that they've been providing most of the care for. And for all young adults, we're often trying to work toward a greater independence, and that can be very challenging. We have to help our population negotiate the NDIS, and that's been a massive part of our work in recent years. And then we have to plan for hospitalisations. So I mentioned already about the ED presentation plan, and planning for hospitalisation is a similar thing. But if you've got, you know, a 2-to-1 care model at home, how does that work when you come into a single room large hospital where the nurses don't have that kind of staffing ratio? How's that going to look? How's that going to be handled? And you know, how can I feel comfortable about being admitted to hospital when I don't know what's going to happen? And so these are the things we need to address. So I've mentioned that we've sort of accidentally stumbled on a torrent of people that love our model of care. They're flocking to it more and more. The clinicians that have referred to us in the past continue to refer, and more clinicians have heard about us as a service for transition. So how can we forward plan for MACS? Because we don't currently have the data to show merit of this service for this population. In fact, when the new RA opened, the outpatient services were, you know, remodelled and are smaller, and we don't have a dedicated clinic space for MACS. We have certainly the director of our service has been looking at that, but really the young adults, from the time when I first received my 21-year-old with 21 medicines, the shifting focus towards this group of patients is still a new thing, and we haven't quite come to grips with that. Our staffing model is such that there's a few of us that are interested in seeing these young adults, but not everyone in the MACS clinic is keen to see these young adults, and I think we need to accept that if we're going to continue to see this population or grow the number of these young adults that we see, the staffing model will need to be able to meet that need. So it's not just about whether I'm happy to see them or my colleague Alice O'Connell is happy to see them. We'll need that support from our pharmacists and our nursing staff. And as I mentioned, it is an interprofessional model. So I want to show you a little snippet that's got a number of my colleagues explaining what they do and how it works. So I'm just going to share this video with you.
System. So what we try and do is try and navigate that for them. First of all, by introducing ourselves with a nursing assessment. So we phone them up and we get a bit of background about what has happened in the past, health-wise, who they're seeing, what medications they might be taking, and then we kind of gather that all together.
So we use it as, you know, I guess it's a good way of touching base with people when you don't know them, under the guise of a nursing assessment. So we ask them all sorts of questions, and it also helps us to identify any areas where they could do extra support, and it also allows them the opportunity to tell us, you know, where their care is lacking and what they'd like to see from our service and how we help them. The nursing role for this particular group of young adults moving across to adult healthcare is around communication, building trusting relationships and coordination of care. So I think the two most important that we spend a great deal of time on in the first instance is around building those trusting relationships and communication.
Well, managing medications in this population is often a significant task, and it also may need to be managed by professional carers. Medicines can also be a significant cost. So we can help by focusing on simplifying medication regimens and explaining supply and formulation options to make it easier for them. So parents of our young adult clients who are carers of their children develop considerable expertise. And so my conversations with parent carers focus on learning how they manage their medications at home and understanding the challenges and helping them find solutions.
We provide care both on the phone. A lot of our service is on the phone, where we try and be available for questions, any insecurities, any worries, anything like that. They can contact us via the phone. That's usually Monday to Friday, 9ish to 5ish. And also we see parents and adults in the clinic, but that can also be via telehealth as well, because we do realise that sometimes it's very hard to come into a hospital scenario.
Oh, I think it's trust. They've had 18 years of having care provided by the same core group of people, and they come to a different environment, and it's, you know, a whole lot of people they don't know. There's probably different expectations, I guess. In the adult sector, we assume, rightly or wrongly, a certain amount of independence. So I think it's about like they feel anxious, and we want to support them, but we also want to encourage that independence in them as well, because they are young adults and they're changing all the time, and makes them feel good to take some ownership of their own care. So I think, you know, it is the trust in care providers is usually the biggest hurdle that we come across in the first instance, and so we work really hard around that, and we do encourage them to make us their first point of call for any issue. You know, nothing's too small to ring. Sometimes they just want to sound off And other times it's around, it's around changes to management plans or crisis management. So it's varied, but I think that whole relationship really is the most important thing,
because we all communicate together, trying to get the best outcomes for the patient.
So that says more than I could say individually by allowing my colleagues to say their bits. And just to finish off, I just wanted to recap with what I said in the beginning, that I think that the core values of the clinic are around holistic care, an interprofessional model, and patient-centred. And this is a good model of care for vulnerable populations because it's a good model of care for everyone. And I often hark back to that, I have the same philosophy around cultural safety. A good model of care is a good model of care for everyone. And that's why this works. I mean, it might be different to provide it. I'm not being glib about that. This has got its own challenge, but it's a good model. I'd like to acknowledge a few people. The interprofessional staff are really the essence of my life in this clinic, and they do a great job. I'd like to credit Saper Shakib, who really founded the first drug optimisation clinic and then reworked it into MACS. He's a visionary, and it's been great. Even though he said that I saw different people than he had intended, it's okay. Nicholas Farinola, who's the current leadership for our clinic, and is looking for ways to help us change and continue. To Dorka, who provides our administrative support, and to my general physician colleagues who give their time to this clinic willingly, like myself, because it's a great model of care, but particularly to our head of general medicine who supports us in doing that, and to the many general medicine advanced trainees that have come through the clinic, and now some of whom who work as consultants in it. So we are moving on now to, because I've been very fortunate in being part of the transition group at CEIH, and we will work now towards doing some qualitative research and data collection in the form of patient journey mapping. But I think it's time for us to start to get some other quantitative data from the clinic to try and make sure that we can move forward and I guess justify the need for a more sustainable model moving forward. Thank you very much.
Thank you, Jo. That was fantastic, really comprehensive and wonderful to see the team in your video. That's a real, as you say, it says so much more when you can bring the team along virtually as well. So really appreciate that. Before we open for questions, I just want to reiterate for those of us who weren't able to join us on the day, that if you do have a story to tell and you'd like to get in touch with us, if you've succeeded in solving a problem, or you've learned something worth trying, any ideas for us about what we could do in the future, please don't hesitate to get in contact with the CEIH. We'd love to hear from you.